which is introducing our president. I just wanted to do a few reminders. One, if you've just come in today, please remember to drink water, moderate alcohol and caffeine to make sure that you deal with the altitude as best as possible. We want to make sure everyone is safe and healthy while you're here at this health conference. And also to remind you that we have a champagne and s'mores reception tonight over in the Meadows from 10 p.m. to 12 p.m. after the session with Mehmet Oz and his daughter Daphne Oz, which should be quite fun. And we also have 2 items for you out in the lobby as well. We have the bookstore, and we also have a complete biometric scan that GE is offering for free as well in the lobby. And it's a little bit depressing, but it's very enlightening. So we invite you to partake in that. It tells you your lean muscle mass, your bone mass, your body water, your weight. It gives you everything, and then it compares you for other people your age and height. You just go out there and you step on the paddles, and it tells you everything that's wrong with you.
No, thank you. I have a wife to do that, yeah.
So please join me in welcoming Walter Isaacson. Many of you know him as the president of the Aspen Institute, of the former president of CNN and managing editor of Time magazine. But few of you may know that he was also the brainchild of his is the Aspen Health Program here, and it was his idea to bring together the Aspen Health Forum that would really be a place where people could come together and learn about health and science in a whole new way. So please join me in welcoming Walter Isaacson.
Thank you. Thank you very much, Michelle, and I want to thank our partners from Time and Time Inc. and actually introduce who's the president of the news division of Time Inc., or I've almost got that right, I'm sure, but he's the one sponsoring this with us. Good to see you again, Mark, and it's my great pleasure to have Ron Williams here with me. All of you know that Ron is the CEO and chairman since 2006 of AETNA. AETNA is an incredibly successful company. Nevertheless, Ron insists on being one of the foremost innovators in the field and somebody who's really been an agent of change, not just within the insurance profession, but also when it comes to the health reform movement. And I was just going to start by asking you why. Why have you thrown yourself so personally into health reform and your company into it when things are pretty good right now for the insurance industries?
Well, I think one of the reasons that I personally focused, and I think why the company is focused, is fundamentally we have 45 million people in the country who do not have access to health care services the way that I, my family, and the people in this room have access. And I believe that there is a huge opportunity to segment that population, understand who they are, and develop very specific solutions that can help them get access to health care services the way that we do.
You know, Tom Daschle sitting up here earlier this morning was talking about the need for a board that would take out of Congress and other things but make it truly professional, how we perhaps allocate, can I say, the healthcare dollars and figure out what we do. Do you think that should be a component of healthcare reform?
Well, I would back up and talk about kind of broadly a few issues. I think that when we talk about healthcare reform, one thing we're talking about is Medicare and the rate of increase in Medicare, which I think is probably pretty important to the baby boomers here in this room. So I think that's one trend and one set of issues of how do we maintain Medicare. There's another set of how do we slow down the rate of increase for those of us who tend to be in the employer-sponsored system. And that represents about 1 million Americans. And we all know that the rate of increase there has been pretty substantial, and the question is, how do we get hold of that? And then there's the question of where does the money come from, and how do we pay for this 45 million that we're bringing into the system? And so I think the whole question of whether there is an advisory committee or a new group formed really is focusing on what is it we need to do in order to get at that. And I think one of the fundamental issues is we have to change how the healthcare system operates so that we emphasize much more prevention, wellness, and we really change the incentives in the system to really focus on quality of care.
What does AETNA have to get out of it? What are you looking for AETNA and for the industry in general?
Well, we think that if we're going to make change, we want to be a positive, nonpartisan contributor. One of the things that we find is that people often don't understand our role in the system. They don't understand our business model. And they often view both the healthcare system and insurance in ways that really won't be helpful in terms of reforming the system.
Wait a minute, give me a good example.
Let me give you just a good example. One of the things that we often struggle with as a sector is, why do health insurance premiums go up? And if we can control health care premiums, will we control the rate of increase in health care? And the answer is that the health care premiums are really directly driven and a result of health care. Now, we all want more health care. And I think the question that we struggle with is, how do we slow down the rate of increase in health care services, but do so in a way that people are getting access to all the prevention, the needed services that they need. So one area of focus is really this link between why premiums go up, how do we slow down that rate of increase, and at the same time make certain we're all getting access to the wonderful technology, including, I guess, the biometric scan that's available outside.
Would a public plan help accomplish that goal?
You know, the short answer is I don't believe that a public plan will, for the following reasons. The structure of the public plan as it's been proposed really is a situation where the government plays two roles. They're both a player in the game or a participant in delivering health care services, a health plan. At the same time, they would function as a referee. Now, the fundamental thing that makes a public plan or the government plan a real challenge is Medicare actually pays most hospitals substantially less than the employer-sponsored system. And so if we have a government plan, what we're going to see is lower prices to consumers. But those lower prices will come from underpaying physicians and hospitals, which will in turn cause the hospitals to have to raise prices to the employer-sponsored system. So we tend to think that a much better solution are public-private partnerships, that if instead of having a government plan, let's figure out what the problems are and let's develop very specific and focused solutions to solve those problems.
Would that be a little bit like Olympia Snow's consortium plan?
Yeah, I think Olympia Snow, Senator Conrad from North Dakota has talked about co-ops as an example, as something that would be a very different approach. I think that the market needs competition. I think competition is good. The fundamental thing we have to make certain is that the hospital delivery system is receiving enough compensation to be there when we need it. Mm-hmm. There's plenty of opportunities for hospitals to be more efficient. And what we want to do is look what we need to do to be more efficient ourselves as health plans, but how we can put the focus on creative simplification and the focus on improving quality.
How can hospitals be more efficient? Not just administrative.
Yeah, not just
that's too easy of an answer. I mean, what can you do in terms of healthcare to say this is not an efficient procedure, even though the doctor may want it and the patient definitely wants it?
Well, I think it really all starts with the physicians. And I think we have to recognize that physicians really should be and are in charge of our health care. And I think what we have to do is look at the recommendations of the specialty societies, the Cardiology Society, the Endocrinology Society. They do enormous research. They publish clinical guidelines. And I think one of the things we can do is look at the care that's going on in their hospital and look at the extent to which the care that's being delivered is consistent with the recommendations of the physician community. And what you find when research studies are done by RAND and other areas is that the recommended care is only being delivered about half the time. In many instances, either the things that should be happening aren't happening, or the things that aren't recommended are in fact occurring.
In other words, more expensive things are occurring that aren't really recommended by best practices.
Correct. And in some instances, the tests and procedures aren't being done that in fact are recommended by the particular specialist.
Isn't that something the insurance play a role?
Well, I think we do play a role, and we think that there's an important opportunity around the whole area of health information technology. That one of the things we have to do is really connect the system, use technology to transform healthcare as we've transformed every other aspect of our society. How many of us have in fact had a test conducted and gone to see a different physician and really had to have that test reconnected? And often a physician is seeing a patient where that patient's complete pharmaceutical history isn't available. They don't really know all the medication they're on. that's something that could make a huge difference.
But you know, a lot of people are afraid of electronic medical records, which is what you've basically just talked about, because they're afraid that their insurance company will get a hold of their electronic medical records and they'll be in trouble. How do you solve that?
Well, I think that's the fact that the insurance company already knows.
Oh, okay.
So we should
That's
start
right.
there. And I think the question is, are we using the data to inform physicians about the care that the patient is receiving? Now, it's the patient's records, and we have to respect the confidentiality and privacy. And the patient may choose that there are certain things they don't want shared with other physicians. But if you ask physicians how often they ask a patient what medication they're on, and when they actually get to the bottom of it, they get an incomplete list that the patient is taking a medication that they got from the dermatologist that may be contraindicated for their kidney condition.
You know, but this is such a good idea, and yet I'm on a regular insurance plan. I have a doctor here who's probably in the audience, a doctor from Aspen, and also sometimes in Washington. I go back and forth. I still really get electronic medical records where they can share. Why doesn't my insurance company almost force it on me and the doctor so that they can be more efficient?
Well, I think the question that we actually have a solution for. I think we have at Aetna invested in the past 4 years about $1.8 billion in health information technology. And we've rolled out and have 10 million of our members who actually have their own personal health record. And so the data that we have that includes all of the medication they're on, it includes whatever lab results that we've been able to collect. The member can also supplement it with a health risk assessment. It's their record. They can choose to have it shared or not shared. It's not data that we want to keep or use. But what our members then have the ability to do is either download it or transmit it to their physician. And so we think that this is a transition period where if we set the clock forward 10 years or so, we'll find that members will have electronic personal medical records that the health plan may have, which will really be transmitted to the physician and dock with that physician's electronic medical record.
And do you think then the insurance company should or could say, you know, you really don't need another MRI based on your electronic medical records?
Well, no, I think we're getting into an area I think is very important, and I think that, and maybe let me talk a little bit about the role we play in the system, because I think it's inherent in the question. Health plans sit in a very difficult intersection, in the sense that an employer or a plan sponsor comes to us and says, I'd like to buy health insurance for my employees. The federal government comes to us and says, I'd like to buy health insurance for the people who work here. And we say, you can have good, you can have better, or you can have best. And they say, gee, we wish we could get best. We wish better was in our budget, but we'll take good. And so there is a judgment about the comprehensiveness of the benefits package that we sell. The member really wants to have access to everything. And so one of the roles we struggle with is the tension between the benefit package the employer purchased and what the member wants. Now, the physicians who are part of this whole dialogue are looking to receive fair compensation, and they're looking to really apply their clinical judgment to whatever care that particular patient needs. When we see an intersection where something's about to happen that is unnecessary based on the clinical guidelines of that particular specialty, then we do, in fact, notify the physician and really encourage them to take a second look.
Do you think it's important to get, or possible ever, to get away from just fee-for-service being the fundamental way insurance works in the healthcare here?
I think this is an area where the short answer is yes, it is. But I think we have to be mindful of the past. I was talking to someone the other day in this area, and the example I use is we're concerned about the rate of increase. But if I told you that I could slow down the rate of increase in healthcare costs, reduce it to 8%, 5%, 1%, and then take it to a negative 1%.
The rate of growth.
Rate of growth year over year in healthcare expenses, you'd say that'd be pretty good.
Yeah.
Well, that's what we did in 1992, 93, 94, and 95. But the way we did it was really a way that the American public wasn't comfortable with.
That was the HMO model?
What we did was we said everyone has a mandatory medical home called a gatekeeper, and that person must authorize all your care. We also said that one of the ways we will slow down that rate of increase is we're going to narrow the network of physicians that you can see, and you can only see those physicians. And we said we're going to create something called bundled payments, where we're not going to pay each doctor for every activity. We're going to pay you an amount of care to look after that population. So I think what we found was that consumers demand choice. And consumers, I think, were and are appropriately concerned about getting the right quality of care. So I think the answer is, as we try to move in this next incarnation from fee-for-service, which I think we have to move from, to bundled payments, to networks that focus on quality of care, we have to make certain that we don't repeat the errors of the past, and we have a very strong eye on quality, not just on the payment mechanism itself.
Yeah, you know, I remember being moved to an HMO plan at Time Warner, which was probably not, they weren't the cheapest plans being given out. And I kind of liked it, but then it disappeared because so many people resisted that notion of not having fee-for-service and my doctor, individual, choosing everything. So how do you get from here to there?
Well, I think the one thing that we know is Americans like choice. And I think as we look at changing the system, that the system we will end up with in terms of evolution will be a uniquely American system. And I think what we have to do is make certain that we're incenting physicians and hospitals to work collaboratively in groups, in teams, with the focus on prevention, wellness, and really managing the health of the population, so that we change the bias from do a procedure and get paid, or see a patient in the office and get paid, to I'm responsible for making certain that everyone gets their prevention, they get their checkups, they're getting all of the prevention and wellness care, and my job is really to manage the health of that population. And so I think
are you in favor of individual mandates where you got to have insurance?
Yeah, I think one of the ways that we believe we can get and keep everyone covered is for the health industry, particularly in what's called the individual insurance market, where there are about 18 million people who buy individual insurance. Now, in most states, there is something called medical underwriting, where your health status is assessed in order for you to be eligible for individual insurance coverage. And roughly about 12% of the people who apply don't pass medical underwriting. What happens is it's a fairly small number among young people. When you get into your 50s and 60s, it tends to be a larger number. What we've said is we believe that the insurance industry should do away with the use of health status. And I think the health insurance industry has agreed that is something we should eliminate.
Okay.
What you have to do then is you have to have an individual coverage requirement so that everyone has to have insurance. And that means that those who can afford it should pay for it, and those who can't afford it should receive some type tax credit, subsidy, or some other mechanism. If you don't do that, what happens is people will buy insurance when they need it, use the services, and then drop the insurance shortly thereafter. What that will mean is it will be so expensive and unaffordable that it really will not be something that's broadly available.
If I were, younger, let us say, and living in a state like New York in my 20s and 30s, the way we have it now, would you recommend that I buy insurance, leaving aside your Aetna hat? But the way the system is set up, shouldn't I game the system the way you just told me?
Well, I think what you're describing is exactly what happens in New York and New Jersey. And what we see there is that someone who lives in Pennsylvania will pay 25% of the premium that someone in New York pays.
You're kidding.
25%. Now, here's the dilemma. The dilemma is choices have to be made. And I think in New York, the legislature made a choice. And the choice was, we want to be certain that everyone can get insurance all the time. Now, we have something we call companion solutions, which means that's a great choice. If you want us to give insurance to anyone, there must be a companion solution that says everyone must come in. They didn't do the companion solution. They did the easy part. So what you find in New York is you can get insurance whenever you need it. People wait until they need it and get it. And so therefore, it's extremely expensive in the context of a young person who really can't afford it. There was one other change I think it's worth spending just a moment on, if I may, which is New York also uses something which called community rating, which is a simple way of saying that the insurance rate is the same for everyone. Now that sounds very fair and represents one way to solve it. But I think when you look at the cost of insurance, if you're 25 years old, the cost of your underlying insurance might be $125 because you use less. When you're 60 years old, that cost might be $750. Community rating average that rates together. And what it does is, it in a way is a cost transfer from young people to the older.
And so if I'm young, it makes no sense for me to buy that insurance.
It makes no sense for you to buy it because it's so expensive you can't afford it. Right. And I think one of the big things about insurance that we struggle with is the most affordable insurance is that insurance that covers everyone and has a broad distribution of people in the insurance pool. Some who need it today, some who need it tomorrow, and others who don't need it for quite some time.
And that means if you did something like that, you wouldn't look into pre-existing conditions.
No pre-existing conditions, no exclusions, everyone's in, everyone's covered. But the trade-off of these companion solutions is we'll cover everyone as long as everyone has to have insurance.
In other words, you can't be forced to get rid of the pre-existing conditions things economically until we have this broad thing which says everybody's got to be in the system if we're going to do that.
Or when we are forced to as an industry, as in New Jersey, people can buy the insurance whenever they need it, but the real issue is affordability, is keeping the product as affordable, and that means a balanced distribution of risk. We need the young, healthy people paying the premiums to keep the premiums affordable for the older. So there has to be some balance.
You know, you've been very personally involved in the reform debate that's happening in the past few weeks, and no doubt you'll have to go back. By Wednesday, it's supposed to be coming out of Waxman or whatever, and I'm sure you'll be involved. Tell me what you've been doing. Have you met the president on this?
Yes, I've met with the president. I've testified before the Senate Finance Committee 2 times. I've testified before Senate Health, Education, and Labor before Ways and Means. What we're doing is really educating the decision makers about the implications of their choices. If it comes to, just to use a rating example, there's no right or wrong answer. It really is being clear that you understand the implications of the decision. So what we do is we do independent studies by independent firms. We share those studies. We share the impact that programs we've had, things we call disease management programs, condition management programs. We really are out educating the decision makers about the implications of the options that are being considered.
What has surprised you in the debate? I mean, the past few weeks of the debate. So.
I would say one of the things that was the most surprising when we started down this process was the lack of understanding of the connection between the health premium and the cost of health care. That for some reason it sounds very simple, but people really believe that the premium had nothing to do with the underlying cost of health care services. And so getting that connection...
Wait, and now let me go back to President Obama, who you've talked about. I know he understands that connection, but somehow controlling health care costs seems to have gone by the wayside a bit.
And I think that is one of the critical issues that we spend our time talking about. And I think some of the things that we can do, for example, that we talk about controlling health care costs, is if someone has diabetes and they don't understand their condition, and they visit their physician, and their physician tells them things to do, but they really aren't comfortable asking more detailed questions, and they go home. And then they have do things that exacerbate the condition. So we do things like have nurses who call you at home, ask if you'd like to be educated about the condition, talk to you about your diet, give you a list of questions to ask your doctor. And so it really is recognizing that a lot of the care that can slow down the rate of increase happens outside of the doctor's office and can result in clinical support.
You know, we got so many more experts here than I am, and I'm asking all the questions. Yes, right there. You were first, yes, and then I'll come up. Oh, is that?
So in 2003, Congress passed MMA, we got the Medicare Advantage program, which is probably the closest thing to the way we're going to go in the future in the sense of risk-adjusted, capitated. There was a 14 to 18% overpayment, and President Obama very negative on that program, feeling that that overpayment wasn't used by the industry to drive better care, better primary care, better coordination of care. Why did the industry fail to use that up?
Well, first I would say I would agree with part of your facts and disagree with part of them.
And restate it a bit for those who didn't hear the answer.
For those who didn't hear the question, it's a question about a Medicare program where seniors can elect a private health plan and where the health plan receives reimbursement from the government for that. I would start with the fact that I think it's fair to conclude that the level of reimbursement the plans received was greater than anticipated. And people, whether it's 12, 14, there's a lot of debate. So I would agree with that assertion. I think what gets missed is the health plans by law were obligated to take that money and convert it into benefits for seniors. And what we found was seniors got extra benefits that were extremely attractive, particularly to low-income seniors. Now, it's also fair to say that those benefits are more than they would get if they were in standard Medicare. And if the Congress and the President doesn't want them to have those benefits, they will be eliminated and they will get benefits that are much closer to the base Medicare plan. But I think it's not fair to say that the health plans took that incremental money and put it in our pocket. We took that money and placed it into incremental benefits, principally for low-income beneficiaries who benefit from it. As those payments are reduced, those benefits will be reduced, and those seniors will have a less comprehensive benefit.
Is it Betsy? Is that you? I can't say. Yeah, okay.
Have you had any experience in the state of Massachusetts? And if so, could you comment on it? And the reason I ask is that state represents one model which we may migrate to, where health insurance is required of all citizens. And my understanding is that the state is now dealing with the issue. While they've got near 100% enrollment, they're struggling. And the legislature may be dealing with the issue now of what you described as bundled payments.
Yes, I Massachusetts quite extensively, and there'd be a couple of things to start with. One is Massachusetts started down this road in 1992. And the first thing that they did was they chose to go to a community rating approach, which resulted in a lot of turmoil in the market. 4 years later, they decided to go to guaranteed issue of insurance, which is elimination of pre-existing conditions and health status. It took from 96 to 2006 to decide that they needed to go to the companion solution of requiring everyone have health insurance. Now, what they did was they solved the access, and I think one of the things that they should be complimented for is a good collaborative, in their case, bipartisan solution, got all the stakeholders around the table and figured out how to get something done, which we think was terrific. I think what they are struggling with is they did not tackle the fundamental affordability, and they also continue to have a very rich benefit plan with lots of, the term we use are mandates, which are required benefit packages. For example, a requirement for something like unlimited in vitro fertilization, which if you're a couple who's trying to have a family, is an extremely important issue to you. But I think these are difficult issues policymakers have to decide, which is how much more do we charge everyone for some particular benefits that are important. In Massachusetts, they have a very rich benefit. The prices are extremely high there, but they've been able to bring everyone in. So I think the take-home message for Massachusetts is that you can, in fact, create a system in which everyone's covered. You can, in fact, eliminate health status. But if you do not find a way to really change the fundamental incentives in the system so that physicians and hospitals are incented to look after the health of the population as opposed to paying for and getting activity, it becomes something that's not affordable.
So how would you change the Massachusetts system?
Well, I think they're doing a good job. They had a statewide commission, and what they're looking at, and you will hear words like bundled payments, what they're looking at really is how do they go back to a capitated model of giving a pool of money to a group of physicians and hospitals to look after the health. And I think as we go down that road, we have to be very mindful of the quality, of the access, and of the legitimate patient and consumer concerns associated.
And on a more specific issue on that, where you mentioned in vitro fertilization, let us say, who should make the determination whether that should be covered? Should that be, you said policymakers?
Yeah, I think it has to be a decision that's made either through the legislative or regulatory apparatus. I think that these are very difficult decisions. I think Senator Daschle's approach is one that could, in fact, work. Because I think there's always a set of circumstances in which someone really isn't getting something that they feel is extremely important to them. And I think what we have to look at as a society is, are we going to have a small group of people who have everything when we have a group of people who aren't getting access to basic health care services?
Yes, Marty, is that you? Yeah. Sorry, with the lights in my eyes.
One of the things that I have not heard in this discussion is, how do the hospitals get capital to modernize and keep up with technology? In New York City, half the hospitals or more are in negative margin. The successful ones are from 2 to 3% margin, and the capital, if they can continue, essentially. I don't see any discussion of capital for hospitals.
How do hospitals get the capital cost to cut to the
Yeah, I think it's a great question. I think, in a way, it comes back to the level of reimbursement. And one of the points I try to make is, one of the most important things Congress could do, as opposed to a government health plan, is actually have Medicare pay its own way in terms of the cost of care that's delivered in hospitals across the country. And we think that that, in fact, would be one of the major sources.
That would bankrupt Medicare.
Well, then I don't know whether it would bankrupt Medicare. Medicare is going to be bankrupt anyway.
Okay.
Right now, we're bankrupting the employer-sponsored system, because every employer is paying to make up the difference for what Medicare doesn't pay. Mm-hmm. So I think that, I think one of the answers to your question is that. I think the other is, we have to incent hospitals, and I think many of them are doing a great job. I know many of the executives who run hospitals in New York, of looking at the care that can be delivered in outpatient settings. Many of them make very excellent investments in shifting care from the most intense settings to less expensive settings, outpatient, even in the office, as the technology makes that care curve down. But I think we want and need a reliable and stable, high-quality healthcare delivery system in the country.
Esther, yeah.
I'm curious, how long,
That's right.
when you do your calculations, as you must do as a business, about the return on your preventive measure investments, what's your assumption about how long any individual is going to be your customer? That's the first part. And then second, if that were to change to the person's entire life, which of course is not practical or feasible, but how would that change how you and other insurance companies operate if you really had a long horizon?
Yeah, this is a place where I explained a little bit about where Aetna, about 2/3 of our 19 million medical members are clients of large Fortune 100 companies. They tend to do what's called self-insurance. They don't actually buy insurance from us. We actually administer the plan on their behalf, and the checks are written off their bank account. And what we find in a lot of these organizations is they have a much more longitudinal view of their workforce, and do engage in more population management and make significant investments. When we think about small groups, individuals, where there does tend to be more turnover in the group, there are things you can do that have an immediate return or very quickly. For example, smoking cessation. Getting people to stop smoking is something that we believe can have a very short-term effect. I think the other thing that we see is interesting is that there is generally a shift in even the small employer segment, in the sense that people are much more interested in wellness and prevention, and we see people becoming much more willing to invest in the services that are related to prevention and wellness. There are some interventions that have an immediate payback, some have a midterm, and some have a very, very long-term payback. So it really depends on the particular condition. If you're looking at somebody who has congestive heart failure, helping them in terms of a disease management program can have a very short-term payback. If you're looking at others, it can be longer term. So it really depends on the condition, but there is quite a range.
Grace, yeah.
You spoke about medications and cost. We know that the medications is the fourth leading cause of death in people 65 and older. We know that in 2012 we'll be spending $450 billion, and we spend about $1.23 to take care of problems versus the dollar for medication. In 2003, Congress passed a bill for Medicare that went into effect in 2006, where they originally wanted pharmacists to review the medications, and they had to involve the patient because only the patient knows what they're ingesting. Are the insurance companies prepared to pay a pharmacist to really review, because it could save lives and ultimately save money?
Yeah, I think I would say that's not something that we've looked at. What we have looked at and do believe in is that the primary care physician is a place where we have significant initiatives. And we believe that one of the big losses in the whole transition from managed care was an underemphasis on primary care. And we believe that people should have a medical home. And one of the things that we do, as I talked about the investments we've made in health information technology, is when you have particularly someone who is a Medicare beneficiary and they're seeing 6 or 7 different doctors. Through our pharmacy benefits capability, we know the prescriptions that are being filled by each of those physicians. And so one of the things we can try to do is make that list available to their primary care physician so that they're in a position to really coordinate. But I think the real answer is really a strong re-emphasis on primary care. So there really is one person who is coordinating that person's care, and we tend to think that it should really be their primary care physician.
Yes. Oh, David Kessler, sorry. Yeah.
The industry argues, the general conventional wisdom is the private sector is always more efficient, can do things better than the government. Yet the public plan has become this boogeyman, and the industry argues we can't compete if there's a public plan. So, I mean, in the end, this is going to, one of the big questions is whether the average person, when they see what they're going to pay for, whether that's, they're going to see that this is in their interest. How do you really, the argument against the public plan that you can't compete against that, what's the basis of it?
Well, first off, I would say that I think it's a complete waste of time to argue about it. I think we should focus on what we need to do to get and keep people covered. And I think that the way when I talk to legislators about it, there are kind of 2 rules of our organizational life that most people know. If something created, it wants to live, and once it lives, it wants to grow. And what we find is that the government plan is akin to, and I mentioned this to one legislator, you're running for office. You have a candidate you're competing against. The candidate you're competing against is also the person who is in charge of the election commission in your city.
Hey, I grew up in Louisiana. Yeah.
And so they have to approve your ads. You have to submit your donation list to them. It's difficult, we believe, for the government to be both a player in the game and the referee of the game. And we believe that the only way the government plan will compete is by using Medicare reimbursement rates, which will underpay hospitals, underpay physicians, will result more cost shift to the employer sector, and will ultimately destabilize the healthcare delivery system. And that is the reason that we believe it is not a good idea. We believe we should figure out how we want the health insurance market to work, create a regulatory framework, and impose that framework in a way that we can get and keep everyone covered. And let me pause for a minute and talk about who the uninsured are. There are 45 million people who are uninsured in this country, in what's reported. What people don't realize is that roughly 25% of those people are eligible for Medicaid or the state children's program today. We do not find them. They are not enrolled. They all go to the supermarket. They all go to the beauty shop. If we were serious about reducing the uninsured, we would find those people and we would get them enrolled. There's another cohort who are the uninsured, or about 10%. They're college and university students. We know where to find them. They are relatively inexpensive to insure, and they're in colleges and universities. There also is about 20% of the uninsured are people who are not U.S. citizens. They're in the country perfectly legally, but they're not insured. And there ought to be mechanisms that we can come up with to really develop products and services to tackle that. And so I think that when we think about the uninsured, we're looking at a system where 180 million people are in the employer-sponsored system. We can solve the uninsured problem without rearranging the whole system by focusing on the regulatory changes we need in the individual market and whatever changes we need in the small group market to increase access and affordability.
Waxman's committee will come out with a bill next week that has a public plan and has no mechanism for cost containment. You all are going to be against that?
Well, I think I would wait to see what the bill is specifically. Clearly, the public plan is not something we are advocates of. I think that we believe that ultimately, if we focus, we can, in a bipartisan way in Congress or at AETNA in a nonpartisan way, come up with solutions that focus on the critical problem of getting the 45 million people covered.
They aren't doing it in a bipartisan way, though, are they?
Well, let's hope that if we're going to get something done, the sense I get is ultimately that's what it's going to
So they're going to have to change course and say, let's do a bipartisan bill.
And I think we see different approaches in the House than the Senate. The Senate Finance Committee, the sense I get is that Senator Baucus and Senator Grassley are working hard on trying to find a bipartisan solution that can generate a level of support there.
Yeah, and they've been working with Senator Daschle and Dole even on a plan that would not have a full-fledged, robust public plan and would do cost containment.
And I think it was great Senator Daschle and the former Senate Majority Leaders had put together a great document that was very positive.
Yes, sir. Yeah.
And I prefaced this by saying you guys did a great corporate turnaround in the early part of the century, and you are well ahead of any other plan, big commercial plan on IT and consumerism, which is great in terms of consumer IT use. However, for the last 6, 7, 8, 10 years, effectively, since the end of the gatekeeper model of managed care, health plans have done a lousy job at their main role, which is what should be their main role, I believe, which is keeping the costs down. You can't blame it all on the fact that it's all Medicare cost shifting. Medicare costs have gone up too. Overall healthcare expenditures are going up 3 times the rate of general inflation. And I think now, whether or not, I agree the public plan is kind of irrelevant. We need to figure out the exchange and what the rules are for national insurance and covering the uninsured and mechanisms. But what are you actually going to do in the next 5 to 10 years to actually bend the curve? And, you know, George Halverson, as you know, says that we can do it for 12% of GDP. He has a report out saying that.
Yeah, it's a fair question. And I think one of the things that we've tried to do, and I think it all centered around changing our business model. And a big part of the business model change was recognizing that in healthcare, a small number of people actually spend most of the money. And the question is, what information did we need, what tools, what capabilities did we need in order to be able to support the healthcare delivery system, the professionals, the physicians, and the hospitals? And I think and I think the industry broadly has tried to focus on are things, and you hear words like disease management. It's recognizing that if somebody has hypertension and you can get the hypertension treated, or somebody has diabetes and you can keep them out of the emergency room, or somebody has congestive heart failure and you can help them understand their symptoms and conditions, that a big part of the focus has really been on managing that small cohort in a way that we use the data, the information, the health literacy, so that when they get time with their doctor, they really are optimizing that particular use. So I think that's one element. I think the other element we focused a lot on is transparency, is trying to invest in building systems and data to figure out which physicians in a community are producing the best quality, which tends to have the lowest cost. We've built in about 40 markets across the country something we call our Excel network. The network is not designed to say who's the best cardiologist in town. It's designed to say, when you look at the clinical outcomes and clinical efficiency of the cardiologists based on the data we have, who seem to be the bottom 5% or the bottom 10%. And if you incent patients by giving them the data, they're free to see those persons if they want to, but if you give them the data, maybe you could improve the quality. So I think it's fair to say that we're developing the technology. We don't have all the answers. And I think the other thing that we are very focused on is reintegrating the healthcare system. At Aetna, what we found was a member would be seeing a physician for this. They were in a different behavioral health program, a different behavioral health vendor. The pharmacy data was someplace else. And no one was integrating that data to try to say, wait a minute, this person just had a stroke. They need to be rehabilitated. They may be depressed. Who's screening them for depression? Who's seeing whether they are being compliant with the medication that can help them with depression? And so what we did was really focus on trying to reintegrate all that. So we clearly have a lot to do. We don't have all the answers, and I don't want to give you that impression.
Let me end by asking you a question of what have you learned from the healthcare debate that's going to affect what you do in Aetna, and what should we know about Aetna in that regard?
You know, I think the one message that we're learning, I think it's one we believe, is that the consumer, the patient, is going to be much more engaged in their own health. And no matter what people say, we're all going to pay more. We're going to be much more engaged. There are ultimately going to be incentives for wellness. We're going to reach the point where smokers pay more or less for health care than people who don't smoke. And so I think one of the big takeaways is that consumers are going to be engaged. And what we believe as a business is we have to invest in the tools and the capabilities to help those individuals be a consumer when they can be a consumer, but recognize there are times when they can only be a patient, and they really can't exercise consumer-like judgment.
Ron Williams, thank you very much.
Thank you.
Great. Very good.
Hope you thought it worked well. I did. It was great. Very good. Thank you.